Hello, my name is Sarah Johnson. I'm a research associate at the University of Utah, and today I'll be sharing results on non-contrast MR biomarkers for MR-guided FUS ablations. Cancer recurrence rates for breast-conserving surgery are now converging on or surpassing those for total mastectomy, which is exciting. Focused ultrasound thermal ablation may provide further improvements to BCT as a non-invasive option. FUS offers crucial benefits such as low risk of complication and improved cosmetic outcomes. But since no tissue is resected during treatment for pathological assessment, we need to be able to evaluate treatment efficacy with an acute in vivo surrogate for pathology. MR imaging is a suitable modality to meet this need, as it's already used in MR-guided ablations for anatomical targeting and real-time thermometry, as shown in this example in a breast cancer patient. MR is also used to provide an immediate assessment of the thermal ablation volume. However, there are important limitations to current clinical metrics for this. The 240 cumulative equivalent minute threshold for cumulative thermal dose, or CTD, underestimates large volume treatments and is susceptible to motion and respiration artifacts. Contrast-enhanced MRI, non-perfused volume, or NPV, correlates well with histological outcomes, but due to transient changes in perfusion, CE-MRI is most accurate 3 or more days after treatment. Fortunately, several innate MR contrasts may also detect immediate changes after ablation. T1 and T2 relaxation are sensitive to hyperemia, edema, and hemoglobin coagulation. Diffusion-weighted imaging and ADC can quantify changes in cell membrane permeability. Therefore, our objective is to determine whether a non-contrast enhanced MR biomarker can accurately predict FUS thermal ablation volumes acutely post-treatment. In order to develop this biomarker, we incorporated multiparametric MR imaging, or MPMR, a supervised learning of the MPMR features, and MR-registered histological ground truth of thermal necrosis. We used a VX2 tumor model in New Zealand white rabbit quadriceps to develop this biomarker. We performed multi-point sonication treatments of the tumor region under MR guidance, while acquiring real-time 3D MR thermometry. For MPMR imaging, we acquired 20-minute protocols immediately prior to and after ablation, and an acute contrast-enhanced MR image about 40 minutes after ablation. 3 days later, we followed up with another CE-MRI acquisition. We then immediately euthanized the animal and harvested the quadriceps tissue for H&E staining. All MR images were longitudinally registered to the 3-day follow-up imaging using a novel deformation algorithm, fondly named Avocado, and resampled to a common 1 millimeter isotropic field of view. Details of those registration steps can be found in the reference below. A major achievement related to this project was the development of a 3D histology to in vivo MR registration pipeline for homogeneous or isointense tissues like muscle. This multi-step process achieved a target registration error of about 1 millimeter, which allowed us to have a 3D label of histological necrosis to use as truth for our supervised learning. On the right, we can already see that the acute NPV in blue overestimates the histological necrosis compared to the delayed NPV in green. For our supervised learning of the biomarker, we implemented a voxel-wise classifier with a data set test size of 67,325 voxels from 4 different subjects. The data set was comprised of 3D segmentations of the entire quadricep. This resulted in a class imbalance of about 10:1. We chose to investigate 2 simple classifiers, a logistic regression and a random forest, due to our limited data set and relatively small positive class. The data set was randomly split into training and validation sets with a 70-30 split. In the training data set, we first performed hyperparameter optimization and feature selection with a 5-fold cross-validation. The optimal features were ADC, T2 weighted images, CTD, and maximum temperature projection, or MTP. Finally, we retrained an optimal estimator on the training data set. ROC curves in the validation data set for both of our MPMR classifiers, LRC and RFC, and clinical metrics are shown on the left. Both MPMR classifiers outperformed the cumulative thermal dose AUC scores, and the RFC also slightly outperformed acute NPV. We chose to choose optimized thresholds for the predictive models by maximizing the DICE or F1 score. Compared to the clinical threshold markers shown in black here, the optimal thresholds traded a reduced sensitivity for greater specificity. This is corroborated by an overall higher recall for our clinical metrics compared to MPMR, but an overall higher precision in our MPMR compared to clinical. Furthermore, the random forest MPMR classifier achieved the highest DICE among all models. The logistic regression classifier was comparable to the acute MPV. Also interesting to note, when we used an optimized threshold for CTD, it only slightly improved DICE over the accepted 240 CEM clinical metric. These results suggest that an innate contrast can further inform tissue viability and perhaps correct for some of the errors of the MR thermometry acquisition. Although we have limited subjects in our data set, we still wanted to look at intersubject variability. To do this, we ran a 10-fold cross-validation on our entire data set with our same 70-30 train test ratio. This enabled us to look at the performance of each subject in each fold. Although there is some overlap in subject ROC curves, we did find that intersubject variability was statistically significant. Notably, variability was much lower in our RFC compared to the LRC. Despite intersubject variability, the MPMR classifiers consistently performed well in each subject compared to clinical metrics. MPMR achieved a higher DICE than thermal models in all subjects, and RFC DICE score was consistently higher than that of the acute NPV. To conclude, innate contrast multiparametric MR may supplement thermometry data to generate a more accurate acute prediction of the final histological necrotic volume for MR-guided FUS ablations. In this work, the random forest classifier achieved a higher DICE than clinical metrics in all subjects, and the T2 weighted and ADC features were the most predictive. There are many limitations that we would like to address in future work, including collecting a larger subject pool and acquiring high-quality quantitative MR data. We're also exploring deep learning with our larger data set. Finally, an important consideration for the future is which score to optimize on. We chose DICE, which equally prioritizes recall and precision, but the relative importance of these scores should be carefully considered for the treatment of breast cancer. I'd like to acknowledge my incredible research group at the University of Utah, and especially my colleague, Dr. Blake Zimmerman, who is now in industry, but who developed the novel registration algorithms required for this work. This work would not be possible without this talented team and our funding sources. Thank you all for your attention.